Good afternoon, everyone. Thanks for hanging in there. It's been a long couple of days, but so much wonderful information. I'm Cynthia Neville, and I'm from the Mayo Clinic in Florida, and it's a great pleasure to be here today. I don't have any financial disclosures, but I do want to start by acknowledging the incredible team that I work with at Mayo Clinic, which includes nurses, doctors, therapists, and researchers. I also want to thank the EDS Society so much for inviting me back to be here this year. I love this conference. I love seeing all of the professionals and all of the patients. And I also want to acknowledge all of the people here with EDS and HSD. You're incredible and you're an inspiration. So how did I get here? Well, as a pelvic health therapist, I have worked with pregnant women for most of my career. And women during pregnancy are transiently hypermobile. So they have a high prevalence of pelvic girdle pain. And working with women during pregnancy with pelvic girdle pain, I learned how to work with hypermobility. They have transient hypermobility because of their hormonal status. 70% of women will have pelvic girdle pain during pregnancy, and 30% of them will have such severe pain that they can't work and they can't carry out their daily activities. So it gave me great pleasure to help women during pregnancy to be more functional and get out of pain. So what I do now is I provide consultation for people with pelvic girdle pain and pelvic floor disorders at the Mayo Clinic in Florida, and I see the vast majority of females with hypermobility, and they come to me for consultation, and I love working with them. I'm here today because I hope to share with you the relationship between the pelvic girdle and the pelvic floor that I call the center of the universe, and help you to understand a little bit more how they're interrelated, what signs and symptoms to look for, and what treatments can be offered to you. And that's what I hope to accomplish today. And my hope for you is that you'll recognize these signs and symptoms and be able to get the treatment that'll be helpful for you. So more anatomy. I know you've seen lots and lots of anatomy. I'll go very quickly through this because you've seen the pelvic, oops, wrong button. Let's see the light button. I'm going to point on this stage over here. In red, you see the sacroiliac joint. That's the juncture between the pelvic, the main bones of the pelvis, which are the ilium, and the sacrum. And the sacrum is a wedge-shaped bone between those two ilium bones, and that's called the sacroiliac joint. The pelvis is a ring, and it's joined in the front at the pubic symphysis. You can see on the picture on the right that the joint is covered with ligaments on the front and the back and even in the middle. And the interosseous ligament of the sacroiliac joint is the strongest ligament in the body. These joints only move a few millimeters. These are anatomic models of the pelvis, and because the anatomy is very complicated, it's very useful when patients can see anatomic models to learn more about their bodies. And the model on the left, you can appreciate the ligaments in the back that hold the sacrum and the ilium together. They go all the way down to the tailbone. I forgot to mention that in the last slide. And these ligaments also connect the pelvis to the hip. And the picture on the right, the anatomy, you can see the bowl of the pelvis, and that whole inside of the bowl is filled with the pelvic floor muscles. And on the top of that picture, you see the hip flexor muscles. And if you lift your foot off the ground and put it back down, you just used your hip flexor muscles. We use these muscles all day and all night long. So the function of the pelvic girdle is to transfer the load of the body across these joints from one part of the body to another. And we call this function load transfer. It's this very biomechanical situation here. Forces flow from the upper body to the lower body, across the pelvis and across the pubic symphysis, from the lower body to the upper body, and down the spine and across the pelvis. And there's nothing that we can do and no position that we can be in where forces aren't being transmitted across the pelvic girdle joints. So there's a lot going on in this universe of the pelvis. The pelvic organs live here. We've heard a lot about this already. You can see on the left picture is the female anatomy, the bladder and the urethra. The urethra is the tube where urine comes out of the bladder, the vagina and the uterus and the rectum. And in the male, you can see the bladder also. The urethra runs through the prostate and the penis, and the rectum as well. So the pelvic organs all live in the pelvis. The sexual function lives in the pelvis because our sexual body parts live here. And our pelvic floor muscles live here as well. You've heard a lot of talk about pelvic floor muscles. We'll talk a little bit more about their anatomy. I want to point out in this slide that these muscles, one of the muscles, and you see in green here in the female, on the side of the pelvis is called the obturator internus muscle, and this is a hip muscle. The pelvic floor muscles attach into the fascia of the obturator internus, and this is the direct connection from the hip to the pelvic floor. This diagram simplifies this relationship, this very complex relationship. You can see the red pelvic floor muscles on the bottom that attach from the pubic symphysis in the front to the tailbone in the back, and the organs of the bladder, the uterus and the vagina, and the rectum. The pelvic floor is the floor of the core. The deepest layer of the core is comprised of the pelvic floor muscles. The transverse abdominis muscle, which is the deepest layer of the abdominal muscle, it wraps all around the entire body like a corset. The top of the core is the respiratory diaphragm. We've heard a lot about the importance of the diaphragm. And the posterior aspect of the core are the lumbar multifidus muscles, which run up and down the length of the spine. You can also see the hip and buttock muscles, and all of those muscles attach to the pelvis. So the pelvis has to be balanced above by the core muscles, and it has to balance below with these strong, large hip muscles. So the pelvis has a lot of responsibility with this load transfer and keeping things balanced. And so this is why I say that the pelvis is the center of the universe. And what we're striving for in good pelvic health is balance in all of these systems all together. It can be a big ask. So when the pelvis is out of balance, people can develop pain. And this is called sacroiliac joint pain. It's also known as pelvic girdle pain. In the red, this is a posterior view from behind of the buttocks. Everything you see in red is where the sacroiliac joint can cause pain. It goes down the buttocks, and it can go to the back of the thigh and all the way down the leg. And so sacroiliac joint pain can be difficult to distinguish from pain that might be coming from the lumbar spine or some problem in the hip. At Mayo Clinic, Florida, our research team has collected data on joint pain during pregnancy, and this includes joints from all over the body. In the gray bar, you can see the patient group with HEDS and HSD, and they compared them to matched controls, same age, same number of pregnancies, and those people are represented by the black column. And you can see that in the column on the far left, the vast majority of women with hypermobility had worsening symptoms during their pregnancy. But it's interesting also to see that some stayed the same and some actually got better. And so we don't know what's causing this. We know that women become more hypermobile during pregnancy because of hormones. So what happens then if you're already hypermobile? And this is a very important question for future research. A very common symptom of pelvic girdle pain is a sharp pain during a transitional movement. And a transitional movement means moving from sit to stand. You're in one position and you move into another position. This could be stepping down onto a step, and you get a sharp pain right where that blue arrow is pointing. And this can even happen when rolling in bed. So what happens if somebody is lying in bed and they're sleeping, the connective tissues during pregnancy or in hypermobility, even while laying there, can start to lengthen. So a person can go to bed with their pelvic girdle transferring load very well and have no pain, and wake up with impaired load transfer and sacroiliac joint pain. So it's really important to, when we think of words, words matter. And when we think of sacroiliac joint pain and pelvic girdle pain, I want to really point out that things are not going out of alignment. And this is not the cause of the pain. The cause of the pain is the result of the impairment in load transfer. So small displacements of the joints lead to disruption of how forces are transmitted across these joints. And this in pregnancy has been shown to be caused by asymmetrical laxity of the joint. So one joint is more lax than the other. The lax joint can get stuck or it can move too much. And this ultimately causes this impairment in load transfer, and then all those ligaments I was talking about become sensitive and sensitized. That's what causes the pain. This can, as I mentioned, can even occur during sleep. And that phenomenon is called ligamentous creep. So this is a video. Hopefully it works. Oop. Nope. Want to try to play it? There we go. And the volume. All right, well, when we practiced, it worked. And so I'm just pointing out that this is the model of the pelvis. And that's okay, I can narrate it, you can just keep playing it. And what I'm going to show you here is that across the joints in the front,
the human body transmit across these joints, and this is called load transfer. When the joints lose the capacity to transfer load efficiently, they offload like this. It's an torsion. It's just a few millimeters, but that offloading leads to sensitization or sensitivity of the joints and causes pain.
So sacroiliac joint dysfunction is typically diagnosed by a musculoskeletal provider through examination and testing. It is not diagnosed by imaging or MRI. PTs, MDs, DOs, chiropractors are typically the ones that can diagnose this. And we do so by provoking the similar symptom in the joint through provocation tests. We can also do load transfer testing. And then the SI joint pain can also be diagnosed by injection, where the physician injects a numbing agent into the joint, and if that similar pain goes away, then the joint is likely the cause of that pain. So that's how it's diagnosed. And the good news is that there are effective treatments for pelvic girdle pain. This includes manual therapy or manipulation to mobilize the joints into a better ability to compress and transfer load. And several studies recently have supported these interventions. If the manipulation is helpful, we really like to teach patients how to perform self-manipulations. And this allows them to reset the loading of the pelvis as they need to throughout the day if their joints offload. And we also want to promote movements that put symmetrical forces through the body, through the lower extremities, to try to counteract that asymmetrical laxity. Multimodal means using a comprehensive approach to treatment, and therapeutic exercises are used to restore symmetrical mobility of the joints. These include range of motion exercises, and then also we've talked a lot about the importance of core muscle strengthening. And pelvic belts can be very effective for improving load transfer. These belts go very low around the pelvis and across the pubic symphysis. And people with hypermobility and sacroiliac joint pain often benefit from wearing a belt when they're upright and moving around. And some people also report improvement in their symptoms when they're sleeping using a sacroiliac belt. So the pelvic girdle affects the pelvic floor, and the pelvic floor affects the pelvic girdle. This is another video.
This is an anatomic model of the female pelvis and pelvic floor. This is the pubic bone in the front, and that's the tailbone in the back. So the muscles attach from the pubic bone in the front to the tailbone in the back. The biggest opening that you see is the anus. In front is the vagina and then the urethra. The pelvic floor muscles fill the whole entire inside of the pelvis, and the organs sit in the pelvis. This is the rectum, the uterus, and the bladder. So the organs affect the muscles, the bladder, the vagina and the uterus, and the rectum. The organs affect the muscles, and the muscles affect the organs.
So when the pelvic floor muscles contract, and this is a video too, if you want to hit the play button there, the anal sphincter and urethra and vagina close, and the pelvic floor muscles lift up towards the head, and when they relax, the pelvic floor muscles drop and open. But studies have shown that 50% of females do not know how to contract and relax these muscles correctly, probably because of all of the other things going on, the bowel and the bladder and the vagina and the uterus, and the sensations can be confusing and complex. And last video, the pelvic floor group is called the levator ani, which literally means it elevates the anus. So the anus is the elevator door closes, and then the elevator goes up. What you see in black on ultrasound is a full bladder, and the white underneath it is the pelvic floor muscle. So you can appreciate that elevator going up when it contracts and it coming down when it relaxes. So here's where it all comes together. Impaired pelvic girdle load transfer of the sacroiliac joint can lead to pelvic floor overactivity and myofascial pain. This can lead to urinary and bowel symptoms, such as urinary frequency and leakage and constipation. And conversely, urinary and bowel symptoms can lead to increased pelvic floor muscle overactivity. So these symptoms perpetuate each other. In hypermobile people, we hypothesize that the pelvic floor muscles attempt to add stability to the system. And so because they're trying to stabilize the area, they become more active. Paradoxically, the overactive pelvic floor becomes weak. In other words, the elevator gets stuck at the penthouse. And so these impairments lead to impaired load transfer, sacroiliac joint pain, and perpetuate each other. We've heard the term pelvic floor dysfunction. This is a generic term that talks about all the issues that can happen. This can include pain problems, urinary symptoms, and bowel symptoms. In this picture, you can see on the left where we normally are, our pelvic floor muscles are wrapped around the anus and keep it closed. But when we have a bowel movement, those muscles have to relax to allow the anus to open and the rectum to empty. So there's a lot of reasons that people can have constipation, and pelvic floor dysfunction is one of them if those muscles don't relax or if they contract while you're trying to have a bowel movement. This is called dyssynergy, or paradoxical contraction of the pelvic floor. At Mayo Clinic, Florida, we calculated the relative risk of pelvic floor symptoms in females without hypermobility compared to females with. And females with hypermobility had a higher risk of having pelvic floor spasm, pelvic floor dysfunction, and pain during sex. So the treatment for this is pelvic floor rehabilitation. There are physical and occupational therapists now who do provide this treatment. But first, the pelvic girdle has to be balanced. And oftentimes, this is a missing component. So people go to pelvic physical therapy and they can't get past a certain point, and that may be because the pelvic girdle has not been addressed and balanced first. Pelvic floor manual therapy is a highly specialized form of treatment, and oftentimes this needs to be performed in order to release and relax the muscles so then we can progress to strengthening. And this picture shows the therapist has a finger in the vagina. This treatment can be done in the rectum as well. And oftentimes it's just a few treatments to get those muscles to release, and then we can start exercising those muscles. We always include diaphragmatic breathing. You've heard how important this is. But the first thing is that the patient has to learn how to correctly contract and relax the muscles. So this can be a very gentle exercise, contracting and relaxing until we get coordination and motor control. Then we progress to strengthening. You see on the screen a biofeedback screen. Biofeedback and neuromuscular electrical stimulation can be very effective in promotion of pelvic floor muscle strengthening and training. Usually pelvic therapy involves dietary and behavioral strategies, many of which have been talked about this weekend. There are therapeutic exercises that go along with pelvic floor exercises, so it's not just pelvic floor exercises, again, working on balancing everything. Most therapists now are being trained, many more therapists are being trained. In the United States, there's websites where you can put your zip code in and find a therapist in your community. And so in summary, I hope I've made the case that the pelvis actually is the center of the universe, and that you'll be able to recognize signs and symptoms and get the help that you need and effective treatment. Thank you so much for your time and attention today. I look forward to your questions.